Thank you, organizers, for giving me this opportunity. So, coming to the next slide. So, as you all know, the overall statistics of lung cancer in India, I won't go much in detail about this, but as you know, among the lung cancer, adenocarcinoma is the predominant one, squamous cell, and then the large cell, and small cell, and others. So, in my this 10 minutes talk, I will discuss what is by which method you can detect the EGFR mutations, and as well which ones stands the priority. So as you all know, in IHC, there are only two mono antibodies where you can detect the exon 19 and 21. So here is the data where they have compared IHC versus real-time PCR in exon 19 and exon 21. So as you can see, you all know that IHC is a very subjective. It depends upon the scoring system. And here you can see upon that. Is there a point? Okay. Yeah. So here you can see that they have compared IHC versus ARMS PCR, where at the end you can see when IHC was negative, still the exon 19 L858 are exon 19 deletions between E746 and E750 deletions. There were 17% positive, and there was almost so ARMS PCR stands out with a p-value of less than 0.01. And again, you can see for the L858R, again, if you go down, there are around 28 mutations were positive where IHC was negative. So understanding the significance of ARMS PCR, IHC cannot be considered for the targeted therapy in terms of mutation detection. So always here ARMS PCR stands out as compared to IHC. So just this is an overview of the EGFR. So out of nearly 28 exonic regions, we see the mutations concentrated only among the exon 18 and 21. So here you can see the exon 19 is at the C loop, which has been concentrated at the C helix, whereas exon 21 is at the P loop, and you get to see the L858R at the A loop. So as you can see over here, it is divided majoritarily the exon 19 and 21, where you can see the predominantly high mutations as compared to the exon 18 and 21. So the most frequent EGFR mutations, commonly termed as classic or canonical mutations, are in frame deletions and as the exon 21 L858R as well. So as I mentioned, exon 19, they are the insertions. You get to comprise of insertions and deletions. And when I say insertions, so these are very rare mutations among exon 19, which I will come in the next few minutes. And so what are the rare mutations of exon 18, 19, 20, and 21? As you have seen, apart from exon 18, G719X is the commonest one, but also you get to see E709X mutation, which is the exon 18 deletion and not the point mutation. So in the terms of exon 20, now you can see not only the acquired mutations as T790 mutation, but you also get to see at the baseline of around 2 to 3%. And not only that, you get to see also the point mutations of 768I and exon 20 insertions, where we had missed during by doing the real-time PCR, because there's a lot of importance has been created for this exon 20 insertions, because you are getting to see the lot of targeted therapy coming up. So what are the classification? This is the classification and frequency of EGFR exon 19 deletion subtypes. Now, commonly the canonical is between E746 to A750 deletions, where it is comprised of around 63%. But other than that, also there are some uncommon exon 19 deletions and insertion, which comes to around 37%. The same thing this is another data where they had looked for in the 349 population, where you get to see around 23% of rare mutations. Again, in this another data where they have not only the common mutations of E746 and till A750 deletion, but you also get to see 15N deletion as well. So mutations, there are various types of mutation detection, but each methodology has its own advantages and disadvantages. Like in Sanger sequencing, only at a time, only single gene can be detected. But the disadvantage is that you need to have only at least 25% of tumor cell content in your sample, because it has a very low sensitivity. Yes, allele specific PCR, which is the most sensitive for the single gene detection, but as I said, and it stands over for the Sanger sequencing. It is more reliable, and it can be routinely carried out in the laboratory. But as you, over a period of time, you must have seen, it is not the single gene EGFR which is important to detect. There is a lot of other driver actionable mutations where you need to detect, like KRAS, BRAF, PIK3CA, which are now driver actionable, and you get to see in the lung cancer various types in adeno and squamous and so on. So single gene detection for the allele specific PCR is again disadvantage only because of they're most designed to detect only one mutation at a time, or one gene at a time. And it enables to detect mutations different from those included in the assay. So you need to only you can depend upon the commercial kits. As we have in our experience, we have missed a lot of exon 20 insertions when we use the commercial kits like Cobas in the system, or in the other commercial kits which are available. So you tend to miss the exon 20 insertions on the real-time PCR. Yes, NGS is the answer. But again, if you look only from the single gene point of view, NGS is not feasible. You need to have multiple genetic alterations, and which allows you not only the point mutations, but insertion, deletions, and copy number variations. And it can be performed either on the FFP or on the fresh frozen collected tissue specimens, and now with the liquid biopsy coming into limelight. But as I said, effective implementation of NGS requires good quality DNA and RNA, which is not always present in the FFP samples because of the formaldehyde degradation of DNA. And of course, you need a lot of validation of panels, which can be expensive and difficult for some laboratories in low or mid-income countries. So here we started EGFR testing in 2011, and up till now we have finished around, it's a decade, we have finished around 8,000 EGFR single gene testing on the real-time PCR. And we came across with some interesting features. Now, the overall, the first published data was in the 2013, where overall frequency rate of in Indian population was around 25%. And you can see, interestingly, as till today, the average has remained the same. It has remained the same as 25%. So from 2011 to 2019, we have done around 8,000 EGFR testing. We have come across some interesting features about EGFR. So it's not only, earlier it was to be done only the NSCLC, but we have found the mutations in large cell and small cell lung cancers, as you can see over here. And in that, exon 19 deletion was other than adenocarcinoma, we could see in small cell carcinoma as well, and in the squamous cell carcinoma. Another interesting feature, at the baseline T790 mutation, it is strongly associated with the TTF1 positive, as you can see in as compared with the other markers like Nepsin A and PDL1 or ALK. T790 mutation predominantly is found high with the TTF1 positive. Again, the T790M mutation is again strongly associated with the smoking as compared with the other exon 19 or exon 20 insertions and G719X. Coming to the metastatic pattern, which is, we found that it is highly associated with the baseline at T790M mutation with the local and adrenal, and exon 20 insertions was also found to be high in the multiple METs of the mutation. As you can see over here, again, as compared to the METs, multiple adrenal, liver, pleural, node, bone, and brain, and METs lung. So it was in the METs lung, the T790 mutation was high as compared to other metastases. So our outcome was that, like, the real world evidence, what we have shown in our paper, which has already gone for the publication, that EGFR is mutated at around 25% frequency. 2 to 6% of large cell, small cell, and squamous cell harbors the EGFR mutations. In the middle corridor and a few NER, that northeast region states, shows elevated EGFR mutation frequency as compared to other states. Within EGFR, exon 19 mutations is the most predominant one, following the L858R. Baseline EGFR T790 mutations were observed in 0.8 mutation and are associated with TTF1. And this mutation also showed association with local and adrenal gland metastasis. And a long-term survival analysis is underway to understand the real-world implications of EGFR TKI in NSCLC. So we compared this for the orthogonal testing, EGFR mutations in FFP with the NGS results compared with the RT-PCR. And almost we had around 86% concordance when we compared this with the FFP DNA NGS with the real time as compared to the NGS platform. So approximately we really got a very good concordant rate with the 86%. Similarly, in the EGFR mutations in cfDNA, we also had, when we compared with the orthogonal testing, more than 90% concordance was found with the baseline samples, with when there was a 20,000x coverage, more than 20,000x coverage. As you all know, for the liquid biopsy, we need to have a higher coverage as compared to the FFP, where only 500x can be benefited. But yes, if you are doing whole exome or whole genome, then again 10x, 100x is comfortable with it. But as you can see, when there was a less than 20,000x coverage, the concordant rate was only 55%. So for the liquid biopsy, we need to have a higher coverage when we want to compare it with the FFP samples to get a very good concordance. So when we compared this with the FFP RNA NGS analysis to the IHC FISH-based testing of baseline primary tumors, again, there was a high concordance rate of around 83%. So FFP gene NGS overview and targeted coverage, this we did it in the single gene NGS EGFR testing, like whole exonic regions of EGFR was covered on the NGS platform. Of course, in the routine, it is not feasible to do the single gene testing on NGS. But however, when we compared that, we found that a high coverage was, overall coverage was around 72x between the amplicon size of 18 and 21. And again, when we compared this with the another orthogonal testing, that there was also the concordance rate was very high with the 91% when we compared with the real-time PCR TAC1+. So coming to the FISH amplification. So as you all know, there are 3 types, like you can identify large EGFR gene clusters, co-localized clusters of EGFR and CEP7, large and bright EGFR signal. And as you with the literature suggests that the higher amplification, EGFR amplification with the EGFR mutations has a bad prognosis. However, still it is debatable if EGFR is wild type, whether the copy number amplification, what is the response of copy number amplification to the TKI therapy. So the NGS benefits, and these are the benefits and challenges. High throughput method involving massive parallel sequencing, simultaneous screening of several genes, provides broader picture of tumor heterogeneity, As if you consider the challenges, complex data analysis and interpretation is needed. Complicated NGS, it requires complex technical and analytical validation of assay performance. This was the latest paper of how to have a good laboratory practice when you are developing the NGS in your laboratory. And this is very important, as you know that it is like garbage in, garbage out. So this is my last slide. So what the clinicians should understand, how to advise for the NGS test. So these are the several steps we need to take it into mind. Clinical application, NGS assay selection, which panel, sample selection, bioinformatic interpretation, NGS reports, and the patient communication, which is very important. So do I need to inform patient about possible incidental finding outputs? Yes, definitely. So take home message, EGFR by IHC has its own limitations. EGFR gene copy number or amplification detected by FISH could be a good marker for predicting treatment response to EGFR TKIs in patient with NSCLC. NGS is the need of an hour in the clinic. It is gradually being adopted in the clinic. However, because it detects in a single go about the mutations, copy number, insertions, and deletions. And advantage, advanced NSCLC patient with activating EGFR mutation can derive significant benefit for EGFR TKI. Of course, there are a lot of disadvantages because it's not a cost-effective test. But yes, if you want to only concentrate on single gene EGFR testing, then the real-time PCR is appropriate for single gene testing like EGFR. Thank you so much.
Thank you, ma'am, for this wonderful discussion. If you have any questions, ma'am is always interactive. You can ask ma'am at any time. Any questions? Yeah. Thank you, ma'am. I think.